Single incision laparoscopic surgery is an advancement of currently available laparoscopic techniques. Presented in this video is a single incision laparoscopic incisional hernia repair. The patient is a 61-year-old male who underwent a hand-assisted laparoscopic right hemicolectomy for a sessile polyp. Postoperatively, he developed a wound infection, and 5 months later then developed an incisional hernia. A left upper quadrant Verres needle is used to obtain pneumoperitoneum. A 5 mm optical trocar is then placed laterally on the left side of the abdomen. The incision is then extended to 15 mm, and a second, shorter 5 mm port is then inserted. For this case, we only require 2 ports, one for the camera and one for the instrument. Once we have safely gained access to the abdomen, a brief laparoscopic exploration is performed. The patient has an obvious incisional hernia defect located in the midline at the site of the previous hand port incision. A bipolar tissue sealing device is then used to take down the omental adhesions. Caution must be exercised while performing this dissection to prevent bowel injury. We use the bipolar sealing device to take down part of the falciform ligament as well. This allows adequate cranial overlap of our mesh over the hernia defect. Once the dissection is complete, we will then estimate the size of the hernia defect. Once we've done this, we'll then select an appropriately sized piece of mesh. My preference is to use a larger piece of mesh when possible. I will allow for greater than 5 centimeters of overlap of the mesh over the hernia defect on every side. I use a coated polyester mesh for laparoscopic repairs. The mesh is opened and then oriented with a marking pen. 4 stay sutures are then placed using an O-proline. One of the 5 mm ports is then exchanged for a larger 11 mm port. The mesh is rehydrated, rolled up, and inserted easily through the port. In this particular patient, we placed a suture right in the middle of the mesh to help with our orientation and positioning of the mesh. Then, using a suture passer, we pulled this middle stitch up right through the middle of the hernia defect to help us orient the mesh and get it centered. In this case, we're using a revered needle. The middle suture is pulled through the middle of the hernia defect. The mesh is then stretched out superiorly. We then estimate location for superior transfascial sutures to be pulled through, and then these sutures are then again grasped with this revered needle and pulled through. We then repeat this process by holding tension on the superior stitch, stretching the mesh inferiorly, identifying location for our inferior transfascial sutures to be placed, and then going ahead and pulling both of them through. Care must be exercised this whole time, making sure not to puncture any bowel or other solid organs with the needle. Once we have our top and bottom sutures pulled through, we'll go ahead and stretch the mesh out by pulling up on the sutures. This allows us to ensure that the mesh is going to lay nicely against the abdominal wall and that there won't be any wrinkling. We will then grasp the mesh, pull up on the top and bottom sutures, and stretch the mesh out contralateral to where our ports are, identify the location to pull out that side of the transfascial sutures, and go ahead and place them. Once the top, bottom, and in this case the right side sutures are placed, they're all pulled up, the mesh is inspected to make sure it's properly positioned. We'll then go ahead and grasp the mesh ipsilateral to the ports and pull them up. And again, identify where to pull these sutures through. This, of course, can be the most difficult side to do since it typically is so close to where the ports are located. All 4 sutures are then pulled up and the mesh is inspected. Once we're satisfied that the mesh will lay nicely against the abdominal wall, we'll go ahead and tie them down. If one of the sutures is not properly placed, it's fairly easy to go ahead and reposition it at this point. You can also see at this point we elected to remove the 11 mm port and exchange it for a 5 mm port just to make it easier to maneuver intra-abdominally. This really helps minimize conflict and makes the operation easier. We will now proceed with placing tacks around the perimeter of the mesh. Approximately every 1 to 2 centimeters we'll place a tack. We're using an absorbable tacker here. I prefer this to the permanent metal type tacks. The key here is getting good external pressure with your non-dominant hand and get good counter pressure. This is fairly easy when working contralateral. When the mesh comes around ipsilateral, it's a little more challenging, but is not terribly difficult. Certainly one of the nice options with a single incision approach, if you're struggling to put the ipsilateral tacks, or for that matter any part of the case, you certainly have the option of placing an additional 1, 2, or 3 ports as needed to complete the case safely. At this point, you do want your intra-abdominal pressure about as low as you can tolerate it. We will typically place a second row of tacks around the perimeter of the hernia defect as well. The thought here is that this will help prevent seroma and help prevent early eventration of the mesh. At this point, we'll go ahead and inspect our mesh, make sure it's in good apposition to the abdominal wall. We'll inspect the bowel, make sure there's no bowel injury. Go ahead and deflate the abdomen and remove our ports. We will go ahead and close our fascial defect as well from our incision with an Ovigral. The patient was discharged home post-operative day 1 and has done well. We were able to fix this patient's hernia defect with a 20 by 25 centimeter piece of mesh through a single 15 millimeter incision.